Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. Sickle cell disease is a pretty much worldwide disease now with all the migration that's going on. Worldwide, there's some 300 million folks with sickle cell trait. And in this country, you have 100,000 people with sickle cell disease, and somewhere between 3,600,000 folks have sickle cell trait. And it's a very, very serious disease. Now, when I left off last week, I was talking about the problems that sickle cell disease caused to occur in the kidney. Now, one of the organs that I have not spoken about yet, of course, is the liver. The liver also get affected significantly by the sickling phenomena. You say, well, how so? Well, these are the sickle cell, see? The mouth-shaped banana-type cell. What happens to them is that when they're in the circulation, they get stuck inside the circulation, and therefore blood and oxygen cannot go through very easily. Well, the same thing happens in the liver. When the circulation of the liver get occluded by the sickling cells, then a lot of inflammatory processes develop inside the liver, causing problems such as cirrhosis of the liver, etc. can develop. In addition to that, when these cells hemolyze, meaning they break open, they dump all the material into the bloodstream that they're carrying. Among these material, of course, is the iron, the bilirubin. All that gets stuck in the liver. So the liver can get swollen, painful, tender, and hence unable to remove all that pigment that the red cell dump in there. That's why the person who are hemolyzing, the sclera, the white part of the eye, got yellow. The skin becomes yellow because of the excess pigment that is circulating in the blood that the liver is not capable of getting rid of it efficiently, because the liver is frankly too sick and there's too much of it. Because you have to understand, these cells live to be somewhere around 15-20 days, and a person with sickle cell disease, somewhere around 60% of the blood are sickling at any one time. Okay, that's the SS disease, or the homozygous, if you will. 60%, 60 to 65% blood are sickling. They only have about 35% good red blood cell in them at any one time. So when the iron, in addition to all the pigments that I just mentioned that liver is incapable of getting rid of, also the iron becomes completely back up in the liver, developing iron overload / secondary hemochromatosis. That itself damages the liver, because as the iron sit in the liver, or anywhere for that matter in the body, by necessity it has to be broken down slowly, and in the process of that it releases free radicals, and free radicals are very toxic to tissue in the human body. That's one process. The next thing that happens, because the iron sits there and it's not going anywhere, that itself, by the fact that it sits there, it creates a local inflammation. So the liver is really being inflamed by multiple different organisms because of the sickling phenomena. So this individual, if one were to check their serum ferritin, which is the level of the blood iron that we test, it would be quite high. And we have ways of trying to mobilize that iron, which I will talk about when I get to talk about treatment. Through all this series, this is show number 8, I have yet to talk about treatment. I will be doing more than one shows to talk about treatment of sickle cell disease. Now, in this chapter, in this book, there's chapter 34 is on sickle cell disease, and chapter 6 is on kidney, which I spoke about last week. Now, you can't help the situation. Okay, you could do all the best you can. So all you have to do is be an individual with sickle cell anemia. You're going to wind up with some degree of liver disease, like it or not, because the liver is the organ that really have to get rid of all the debris that accumulates in the body. They have to pass through the liver, and then ultimately the bloodstream pick them up and carry them to the kidney to filter them out. Well, the kidney is sick, as I mentioned last week. So the filtering mechanism of these individuals, most of them not working properly. So things back up into the system, and the liver is taking a beating. So once the liver becomes damaged, then a whole host of other stuff can happen. The person can develop abnormal coagulation, because when the liver, which is where 99% of all coagulation materials are made, is sick. Because of that, then of course the liver cannot produce these things effectively, so someone can bleed very easily, very readily, sometimes spontaneously. In addition to that, there is a part of the blood we call platelet, which is the one that help us to clot initially when someone has a small laceration or what have you. Well, the platelet is going to be low as well, through the same mechanism that I'm talking about, because the inflammatory process that's taking place in the liver can cause consumption of the platelet as well. So it's a very bad situation, no matter how you look at it. Okay, so the liver is not spared one bit. And for those who don't have spleen, they're not going to suffer from portal hypertension. But for those like FC disease, sickle cell, who still have spleen, these people can also develop portal hypertension, because they still have a spleen that can get damaged, as it were, but because of the problem with the circulation in the liver, raising the portal pressure, and then these people can have a whole host of other things that I'm not going to get into because of that process. So it's a very complicated physiological mechanism to understand, but that's the science. Okay, now there's another organ, actually another part of the body, organ if you will, that takes a significant beating from the sickling phenomena as well. That's the bones. The bones suffer tremendously. We need our bones to function, to move. The bone carries the body. That's the structure of the body. Here I have an example of somebody's, this is what we call avascular necrosis, a lack of blood flow. This is somebody's knee, okay? Right there. See, this is all bad. I put the little arrows there. This is all arthritic, and no blood is going there. Well, you say, well, how so? Well, because again, go right back to this phenomena, the sickling phenomena. The red blood cells clogging up the vessels that's supposed to carry blood to this knee cannot do it effectively. And over time, it winds up with no blood going at all, no vessel, and that's called avascular necrosis. Necrosis means it is necrosis, dead, period. And because of lack of blood flow. If you don't have blood flow, you're not going to have oxygen to go into the area. And lack of oxygen and blood flow result in local ischemia, but make the situation even worse. It isn't just arthritic. The vessels themselves has been destroyed by the process, so that's called avascular. No vessel is going there. So this is a dead joint. All that can be done with this is the orthopedic surgeon to come in and just remove that and replace it. Okay, you remove that and it's avascular, meaning no blood is going there. So sickle cell trait also causes arthritis. Now, I haven't spoken much about sickle cell trait. I will before I finish the series, because it has its own profile of symptoms and problems. But arthritis is a very common medical problem associated with sickle cell disease. Very common. Well, it should be, because after all, we're using our bones, our joint constantly. Wear and tear. Ordinarily, we wind up with a lot of osteoarthritis anyway, as we get older. But now you have this sickling thing going on, and from an entirely different mechanism, specifically due to the lack of blood flow and ischemia, you wind up with secondary arthritis in different joints. I just give you an example of a knee, and this is in chapter 34 of this book, which I wrote, that came out a couple of months ago now, The Best of Clinical Medicine for the 21st Century. I wrote this. It's 110 chapters, 516 pages. Okay, so that's the bone. You really have got to understand the necessity that exists for counseling to take place so that people don't keep bringing little babies into the world with this very bad disease. This very bad disease. It's because there are ways of preventing this stuff. First of all, you have to screen the patients properly in the medical practice to see who's carrying the gene. I have people in my practice who I'm seeing for the first time that are in their 70s, and they will have sickle cell trait. Nobody knew about it because they don't bother to do a hemoglobin electrophoresis in these people, because they don't take a look at the color of their skin or the ethnicity when they're taking care of them. If they would, if they were exposed to medicine the way it's supposed to, they would have understood that you have to practice medicine not to discriminate against anybody, but you have to understand the ethnicity, the culture of the people for whom you're practicing. Because if you don't, all you could do is basically do surgery, because the organs can be found in the same location almost all the time, and that's about it. You could do well. The rest of it, you'll do okay, but not well, in my view. Now the medical community finally is listening. A couple of years ago, the American Medical Association gave millions of dollar grants to 11 medical schools in this country who were willing to change the way they teach medicine to medical students. Not only to modernize it, but also to make it more culturally sensitive, culturally relevant, so on and so forth, rather than just pushing students to pass exam, but also to understand what it is they're talking about and who it is they're working with, etc. Now, this week, I just read 20 more schools have received the grant from the AMA as well, because the AMA is really pushing that. And all the other major medical organizations in this country are pushing the notion of cultural sensitivity in medicine, ethnic sensitivity, and the relevance to know who you're practicing medicine for, and the need to practice bedside medicine as opposed to bookside medicine. They're listening. And you've heard me saying that for the last 23 years or so I've been doing the show. Some folks have gotten angry at me, but now here's the reality. You're going to go and argue with the AMA. You go and argue with them. As a matter of fact, getting even better. The pre-med exam, called the M.A.C.P, now it used to be 4 hours, now it is 8 hours. And the extra 4 hours are loaded with cultural sensitivity, ethnic things, all sorts of gender-related things in there, so that at least they know they're picking students who are sensitive to the new era that we're living in the world. That's the new M.A.C.P. So you got to get 8 hours of it now, and so it's been changed. So all the changes are taking place. So all this stuff that I'm talking to you about, I'm not making these things up. I don't make things up. This is all what's taking place, because I read the literature every single day, 24/7. I know what's going on. So if you understand that, then somebody shows up in your office, they are of a particular ethnic group, and you should know what are the most prevalent diseases associated with this ethnic group, so you would screen them appropriately. You can't tell me you're going to have a black person showed up in your office, or a teenager or whatever, in the black community, and don't do hemoglobin electrophoresis in them. What kind of medicine are you practicing? How are you going to have a proper clinical profile of this patient if you don't know what they have, what they're carrying, what disease they're carrying that they can transmit down the line? This is very, very crucial. And that is, in my view, the surest way of bringing down the percentage of sickle cell disease in the world. Okay, so now that I talk about the bone, there's one more organ that I must bring to your attention. The largest organ in the body, the skin, tremendously affected by the sickling phenomena. And the most vexing part of it is the fact that these young people develop severe ulcers in the legs in particular. The ulcers keep getting worse, it won't heal. That's right, will not heal for the same reason. And the reason why the ulcer develops, again, is the same phenomena. The sickling phenomena obstructs the circulation of blood through the skin, exposing it to easy bruising that can then develop into a little infection. And a little infection can move on to a big infection. And someone who doesn't have sickle cell disease, there's plenty of blood flow and oxygen going to feed the stuff. It's easier to treat an infection. But if you have not sufficient enough of blood and oxygen going there, it doesn't take very long for the ulcer to become infected, and the infection kept getting worse. So one of the terrible things that I have seen in sicklers over the years, it is very bad looking leg ulcers, and no one knows what to do about them. You send them to the plastic surgeon, they do all kinds of surgery to try to cover them up, take tissue from here, cover it over there. They lack flow, or they try. Again, you're not getting enough oxygen there. So a lot of the time the surgeries fail. Okay, and sometimes these leg ulcers wind up going into the bone, creating a condition called osteomyelitis, an infection of the bone, which is really awful stuff. Awful stuff, and I've had to deal with those things over the years, and I'm sure thousands of doctors have to deal with it as I speak, and it's a terrible thing. I mean, of all the other issues that these folks are suffering from, now they have this leg ulcer, and it's not a static thing, it's a bad disease. They can't wear certain dress because the leg is exposed and they have big bandage around it, so they have to cover it. A whole lot of other problems that they have to deal with. Okay, so it is a bad disease, suffice it to say. So the skin also accumulates some of this bile salt. You know, when the cells burst, they release a lot of debris, and one of the things they release something called the salt, bile salt. Well, when the bile salt accumulate over your skin, it's not only yellow, it's also itching like crazy. So therefore they're scratching all the time, and somehow they carry the infection and their nails into the area where they're scratching. It is unpleasant. It is unpleasant. So I've given you a little bit of an overview on all the organs in the body that are affected with the sickling phenomenon. Nothing is spared. I haven't spoken about all of them, but I've spoken about enough of them to give you an idea. This is a systemic disease. It is systemic because the blood is systemic. The blood goes everywhere. And everywhere the blood goes, the sickling phenomena is taking place. Okay. Now let us begin to give you a little taste about how we treat individuals with sickle cell disease, the symptoms. Well, what are the symptoms they present with most commonly? Well, most commonly people who have full-blown sickle cells such as SS, SC, SA, they will present with severe pain. And the pain occurs because this is an occlusive disease. And the pain is the result when the occlusion occurs. The area that is occluded, it becomes ischemic, as I just mentioned, and it releases a substance called kinin. To give you an example of what kinin is like, if you hit your finger somewhere, you develop a blister. And you know, if you burst that blister right away, it's going to burn like mad, because it's the kinin inside the blister that causes the burning pain. Well, I want you to multiply that 1,000-fold when this is taking place throughout the body, and these individuals are having pains all over. And this has been going on since infancy. Okay, so pain is the #1 symptoms of the 3 major sickle cell syndrome, if I may use that word. The second problem, of course, is weakness, dizziness, all headache, all these things associated with low blood count, low red blood count. Because the red blood count is low. Remember, 65% thereabout of the cells in the red blood cells are sickling. Only 35%. That's not enough to carry sufficient oxygen. So the lack of oxygen to the brain can cause these people to have a stroke. In addition to the lack of oxygen, as I mentioned before, occlusion of vessels in the brain also can cause them to have a stroke. And they become dizzy. They can't hold a job because they're tired all the time. So that's symptom number 2. Symptom number 3 is, again, individual will show up in the hospital with severe pneumonia. All people can have pneumonia, but sickling people with SS in particular are more prone to have pneumonia, fever, cough. Why? Because they don't have a spleen that is functioning. And when you don't have a spleen, you are partially immunosuppressed. Well, you say how so? Well, the spleen produces and secretes certain material that are necessary for certain bacteria that have capsules to be dissolved. In addition to us giving antibiotic, etc., you need that part of the immune system to be working on behalf of the individual who's infected. Well, they don't have a spleen, so therefore they are immunosuppressed that way. So they're prone to develop infection much more easily, and it's much more difficult, obviously, to treat the infection. So, infection of different types. Name the infection. Have your pick: pneumonia, urinary tract infection. Just name it. Sepsis can occur. So this person shows up into the emergency room complaining of pain. What do you do? Well, you're going to have to examine the patient, get a chest x-ray, get blood count done, give them nasal oxygen, and then make sure they don't have an infection, send some urine off, check the EKG, etc. And then you give them pain medication. And many of these individuals are addicted to the pain medication they're receiving because they've been getting it since childhood. That cannot be avoided. And you should not, let me repeat, should not refrain from giving them sufficient amount of pain medication to relieve it. Now the question is, what pain medication do you give? Okay, people like to use Demerol. Demerol is okay, except that when you use Demerol, it's not the Demerol that's going to ease the pain, it's the breakdown product of the Demerol. Unfortunately, that the breakdown product of the Demerol is very toxic sometimes to the body, in fact can cause seizures, etc. So we're backing away from that. Not only that, it is much more addicting because I guess it's easier to get, what have you. So now the medication we use, Dilaudid, morphine, are the two most favorite medication that we use intravenously when they just come in. Well, you could give it intramuscularly, but don't want to be given an injection. It's very painful, so you give it to them intravenously. And of course, you're going to give them IV fluid. The problem is that a lot of folks don't understand how to hydrate somebody who's having a sickle cell crisis. They're just going to load them up with normal saline, 150 cc per hour, which is absolutely wrong. What is the normal saline going to do for them? There's no nutrition in it. There's nothing in it that can carry oxygen. In addition to that, unless, of course, the patient is in shock, that's different. There's nothing in there that's really going to help the patient besides extending the volume, but you need to do more than that. Furthermore, sicklers have heart problem. They have an enlarged heart because of ischemia and or iron deposit. So they can go into heart failure very easily. So you don't want to be pushing a lot of normal saline on them. They're going to get fluid, yes, but you have to leave room to give them blood, because the number one treatment is going to be blood transfusion. So if you flood them up with normal saline, when the time comes for you to give the blood, an hour or so later after it is prepared, they're already loaded with fluid. And you give them blood which is very thick, then the next thing you know, patient can't breathe. They're in the ICU, they're in the CCU because of lack of thinking. Send the blood to the lab to be cross-matched. It's going to be ready within an hour and a half, sometime less. Give them some IV fluid, maybe 75 cc's an hour with D5 with some sugar in it. Sugar is food. Salt water with saline is not food. So that's clinical medicine. That's understanding how to keep a patient that's very sick in an anabolic condition. When somebody is very sick, they are catabolic. They're breaking tissue. That's a bad situation. You want to help the situation. Normal saline is not going to bring them into an anabolic situation. But if you have sugar there, that will. You have to teach people how to understand this concept. Sometimes I ask myself, who were the teacher of these folks? I have no idea. In any event, I'm going to stop here. Until I see you again, this is Dr. Alcena saying so long and bye-bye.